See, after the occlusion, it can walk. Then, after the transcranial Doppler, the next test is xenon CT. That shows the blood flow. The next test is PET CT for the blood flow. There are many things. So, in spite of all this, there is no 100% test.
No, it's not 100%. But that is a rule of 25%. Na? If you occlude the common carotid on one side, what is the chance of developing hemiplegia?
Up to 20 to 25%.
25%.
May not be acute, may be delayed.
No, 25% mortality.
If it is
Immediate
beyond, it is mortality.
Yeah, that is
mortality 25%.
Then, but 50%.
Sometimes it is not acute, sometimes it is delayed after 5 days, 7 days. I have seen.
Mortality
So,
50%.
in such a situation, when there is no guarantee, what about doing anastomosis beforehand itself and doing resection?
The complications of anastomosis are more than this.
Uh-huh.
Anastomosis means
Very crucial.
you are doing an intracranial, extracranial bypass. There are 4 techniques prevalent. You know, you do a bypass and then resect the carotid. People are doing it, but the risk is very more. You have to start anticoagulant, right here, and then operate in the anticoagulant. Not already easy. So people have developed different technique. The shunt, the carotid stent, like what Maurice does. If suppose at the lateral skull base, the petrous carotid is involved.
Even stunt also had to use aspirin.
No. 2 ways. 2 ways, I tell you. So first, what he is doing, if the carotid lumen is narrowed, the tumor has infiltrated the wall. So he will pass an inflatable stent through the narrow lumen beyond the tumor on either side and inflate the stent little bit. And that is a stent which gets merged with the intima over a period of time, in 4 to 6 weeks. So when he plans any surgery, 4 to 6 weeks before, he will put a stent that merges with the intima. It's a metallic stent. So now, once you operate, you shave off the tumor above the stent. You can remove anything, all walls of the carotid above the stent.
Yeah, carotid will not burst open.
The lumen will remain inside it. So that's a good strategy.
Yeah, then we had to use lifelong aspirin, lifelong aspirin and all those things, even in such a situation.
During surgery, you can put on heparin or something, otherwise you have to. All stents have the same problem, thrombus. Even the simple balloon occlusion, testing only has a chance of complication. People have reported for testing the occluded the balloon for 45 minutes, the turbulence of the blood flow, the stagnation at that level has led to thrombus. It can happen. You cannot say everything is safe. So like in the carotid body yesterday we did, I was sure it was not going very high up. I will remove. Otherwise I showed you the stent, carotid stent. I was ready with the stent. I would put many a times we do, resect the segment of common and internal carotid and reconstruct with the saphenous vein. So that time we keep the flow with the carotid stent. On both sides you put a stent, ligate with the, tighten with the umbilical tape. करो चाहे एक दिन पड़े रहने दो full time for the flow.
And then reconstruction with the mesh.
With the saphenous vein.
Saphenous. They also use some material, no? Prolate mesh or something.
TPFE.
TPFE.
Are you also using TPFE for some time?
Yes.
Something?
Yes.
Neurosurgery also. So in neurosurgery, you do a lot of vascular procedures.
Yeah.
You don't need vascular surgeon at all now.
No, never. No.
Even for anastomosis or anything.
Not at all. Anastomosis and everything we are only doing.
Yes, that's why.
Our microsurgical techniques are, in fact, those are the microsurgical techniques basically. Anastomosis and all those things. And whenever we are doing all our acoustics and all, it's all very complex. That's why vessels are always around over there.
They deal with so many aneurysms.
Aneurysms. Now many a times even this coiling intervention people, the intervention radiologists, they are also many times not able to coil it. just because they are not able to negotiate and all. Then again we have to open it. Now sometimes like patients are nowadays preferring endoscopic. I mean they just want interventional radiologist opinion and all. So if they fail again, we have to do by our routine traditional transcranial approach only. But transcranial approach is it's like a time-tested approach. I mean, if we are well versed with the microsurgical techniques, we can handle almost all the problems. Any kind of aneurysm.
So, like, sir, I would have your opinion. If, like, such tumors, if I'm going in the cavernous, going in the middle canal base, and we need to combine the open approach, what open approach will you give best?
No, but
What will you prefer?
in this case, why open approach?
No, in this case, no. I'm just giving an example.
Okay.
Tumor occupying the cavernous and going in the floor of the middle canal fossa, intradural.
Okay.
And we have to, after removal of the nasal part, we have to remove the tumor with the open approach. What open approach will give you the best access?
Middle cranial fossa approach only.
Frontotemporal.
Yeah, that's the only, because in such cases, I mean now as far as such cases are concerned, I will not at all think about it, transcranial approach only, because this is all accessible through this. There is
Otherwise,
no doubt.
frontotemporal, huh?
Yeah, that is the only approach. Otherwise, I mean, no other way around.
That
I
gives
mean,
you-
I mean, neurosurgeons over there are using
No,
some
the same,
because
same.
I mean we are using the same
Because you
approach.
can easily elevate the temporal lobe and remove from
Exactly.
there. And you can see the lateral part of the cavernous sinus also with the same. In that approach, can you handle the carotid bleed and suture it or
No.
do something?
It's difficult.
If we sacrifice V2 and V3, can we suture?
No need to.
No need to do all this.
In the paracellular tumors.
This V2 and V3 were damaged by the tumor itself.
No. Then can we suture if there is any rent? Can we suture transcranially?
Rent in the carotid.
Rent in the
That's what I'm
that's
asking.
Acha, that okay. That can be done actually, but it's like still.
Do you have that exposure to do a suture with that?
No, it can be done. Suturing.
That
can
is
be
the
done.
limitation of our endoscopic, because we do at the max muscle patch. That's it. More than that we can't do anything. If still it bleeds, can you suture? That's what we are.
Yeah, it can be sutured, but it's still the results and everything is not good. Just I mean, truly speaking, as far as because the access is really not that good.
Can we do immediate anastomosis?
For
Immediate
anastomosis also you need access, na?
That's the problem actually.
For anastomosis you
So
need to claim both sides.
paraclavial and petrous anastomosis.
No, but again it becomes a problem. I mean, even if we try it, many times it fails. That's again a problem to that approach. Access is not
Sir,
really that
in
good.
the rarest of the rare situation, like if you need to sacrifice the carotid, a lot of people have described the superficial temporal artery here to the middle cerebral artery.
STMC bypass. That is the
MCA.
most commonly. Yeah, STMC bypass is the most commonly.
So
used
then you can
anastomosis.
open from here only, the
Yeah,
perional,
Right.
and you can find the middle cerebral. That you can easily do, I think.
Yeah, that is the most commonly done procedure by us actually. STMC bypass, we do it very frequently. That is very
You are
easy.
doing?
Yeah, that is very easy in fact.
So that
STMC
saves the patient from stroke.
most of the times, because that is like a only sort of salvageable procedure just to get rid of all other things, and it does work. STMC bypass. Yeah.
Now,
Only thing is
now
that anastomosis should be very meticulously done. That is very important.
Now,
Otherwise, again,
the
if
important
suppose we
issue
are-
is the timing. Like suppose we are doing here, had a carotid injury packed. Now after an hour or two, if you do the bypass, still can save from stroke.
Not after an hour or two. We have to, hurry up with all these procedures as early as possible, and we have to do it. immediately.
Reversible
Yeah,
damage, no?
yeah, because otherwise it will be a problem. Because we have to do it.
So at the what is the maximum time to do this anastomosis?
Generally, we should do it within an hour or 1.5 hours, because again it will be a problem.
तब तक वही हो जाएगा उधर ischemia infarction.
Yeah, that's the thing.
we are approaching transnasally to convert this and open cranium. How much it will take time?
It will take at least 1 hour.
No, to open and everything.
that-
Open, expose both
open
vessels.
1 hour.
Yeah.
Hey my dear, open it, expose both the vessel, get the
This-
graft also.
Hmm.
This will take at
And then
least
suturing.
minimum. That is the minimum period.
No, by that
Suturing
time
on both
patient-
ends.
By that time, patient may develop hemiplegia.
Huh?
So,
That risk is always
in
there.
that situation, in extensive paracellular tumors, post radiotherapy are very fibrous. Why can't we do prophylactically open this one in the initial itself and try this one? If it punctures, immediately we can do this. We can save this 1 hour time.
Prophylactically, but I mean, nobody advocates it actually. Hmm.
Oh,
See, majority of the patients have a good cross flow. Majority.
Generally, I mean, patients, what you are like, your fear is like patient may develop this one, but just because of the cross circulation and all, most of the times patient
no,
can be
revisions, fibrous, post radiotherapy, and these 3 things.
Still, I mean, we can work out with this in STMC.
Make it ready and try this one. If it fails, immediately do this.
Prophylactically, generally nobody does it actually.